everybody. This is Dr. Fundi. You have joined us on the health matters on Dr. Fundi. Today, we have a very interesting topic, a bit technical, but we will try and make it as simple as we always do. Today, we are reflecting on the World Anti-Microbial Awareness Week. That's a mouthful. But basically, this is a week that was designated by the World Health Organization from the 18th of November to the 24th of November. During this week, we are supposed to focus on one of the biggest public health challenges facing humankind. The WHO has put this issue in the top 10 of public health challenges that are facing humanity. What is this challenge? Well, it's a challenge of what is now called AMR, Anti-Microbial Resistance. That is a situation whereby most germs or a number of germs are now not responding to treatments that before used to be able to eradicate those germs. So we are facing a situation worldwide in all the 7 continents, a situation whereby people are dying annually from germs that previously were responding to, for example, antibiotics. But nowadays, those antibiotics no longer work, no longer kill those germs. And so people are now overwhelmed by those germs, and they are dying from stuff that used to be treatable. So when we talk World Anti-Microbial Awareness Week, we are talking about a week of awareness about the growing number of germs, whether they are bacteria, in which case we're talking antibiotics, or they're antifungals, because we're talking funguses, or antivirals, if we are talking viruses, or antiprotozoals, because we are talking, parasites. So today we are saying, let's focus on this silent pandemic that is threatening to take us back to what used to happen before the advent of antibiotics. I'm not alone, as usual. I've got my co-pilot here, Mr. Sipho Masiho. He's a communications expert, and he's the one who brings a bit of flavor and takes away the stiffness of medicine. So welcome to the Dr. Fundi channel once again, and we are going to have another interesting talk.
Absolutely, Doc. Thank you so much for having me. I'm so excited to always speak to you, and as always, this feels like Doc. I'm learning. Soon I'll be a medical student when I'm done.
Yeah, no, I think you'll do better than who's that doctor now?
Oh, yes.
Dr. Lani. At least there's some theory that you are getting.
Thank you very much, Doc. It's a mouthful what we discussing today, but very exciting and informative.
Indeed. If we just reflect back 2-3 years ago, we were hit by the COVID pandemic.
Absolutely.
Hundreds of thousands of people, and millions of people died across the world. And the world came to a standstill. There is this other pandemic which has been, gradually growing, hundreds of thousands, and now millions of people are dying from this. And the projections by 2050 is that more millions of people are going to be dying from this problem. And so I thought it's important that we give it attention.
Absolutely.
Many people are not aware of it, and it is our duty to create awareness about it. Yeah.
Absolutely, Doc. And I certainly enjoyed listening to our preparations and discussing them with you. But you did want to start with this particular video so that we give context
Yes.
as you have started.
Yes. So I thought it's sometimes better when you're dealing with a subject that is a bit technical to actually have an explainer video, something that simplifies the concepts so that by the time we get into our question and answer, at least people have got a foundation of what is it that we're talking about.
Absolutely.
So over to you.
Thank you very much, Doc. The video is ready.
Following the discovery of penicillin in 1928, antibiotics have saved millions of lives around the world, and the average life expectancy has increased considerably. But the wealth of these miracle medicines is not only a success story. The bacteria have fought back, and today we see an alarming trend. The number of multi-drug resistant bacteria has grown dramatically over the last decades, resulting in millions of deaths due to infections that cannot be cured. What happened? The massive use of antibiotics has stimulated bacteria to develop resistance mechanisms in order to survive. For many years, we did not know enough to take this global threat seriously. And although awareness and involvement has increased, much damage has already been done. Antibiotics are often prescribed unnecessarily for infections that are likely to go away without treatment. In many countries, antibiotics are also sold over the counter without a prescription from the doctor. At the same time, in many low-income countries, lack of access to antibiotics actually causes more deaths than resistance. Multi-drug resistant bacteria spread within hospitals as a result of poor infection control and also between people in the community. Bacteria know no boundaries, and extensive international travel and trade help resistance to spread from continent to continent. Antibiotic resistance does not only affect humans, but also the health of animals and the environment. It is all connected. The unpleasant truth is that antibiotic discovery is not keeping pace with resistance development. Most classes of antibiotics were discovered decades ago. Now, we have entered an era where many commonly used antibiotics have lost their effects. Modern medicine relies on the availability of effective antibiotics. Without them, it would be too risky to perform organ transplants, cancer chemotherapy, or even common surgical procedures. Care for preterm babies would also be at higher risk for untreatable infections. Resistance is costly, both for the individual and for society. Already now, more than 1 million people die every year from resistant infections, exceeding the number of annual deaths from major diseases like HIV or malaria. Antibiotic resistance has been considered as dangerous and deadly as terrorism and global warming. Are we heading towards a post-antibiotic era? We cannot reverse this frightening trend, but we can slow it down. And all of us need to change our behavior and work together to preserve the effectiveness of antibiotics.
There you have it, Doc. Our first video to explain our topic today.
Indeed, I found that video to be, very, very spot on, simplifying the issues so that you don't have to have gone to a nursing school or a medical school to understand what we're talking about. Because otherwise, why are we doing this thing?
Absolutely.
We want to empower the average human being, irrespective of their level of education or profession, to be part of finding a solution to this problem that is putting at risk humanity as a whole. And we may not be able to reverse it, but certainly we can slow down this problem.
So, Doc, my first question to you is, please explain to me and, of course, our listeners, what are the microbes? What are microbes, Doc? I mean, I'm hearing this word for the very first time in class.
Yeah, no. In all the professions, there's these, jargon.
Yeah.
You talk to IT people, they've got their own jargon.
So true.
You talk to people from the other spaces, they've got their own jargon. So we also have our own.
Yeah.
But in simple language.
Yeah.
When we talk microbes,
Yeah.
all we are talking about germs. Ne? In my language, which is Xhosa, we're talking about intsholongwane, germs.
Okay.
In Zulu, they've got a word called amagciwane. Now, you're going to tell me in Tswana, what are germs in Tswana?
No, Doc, I don't know. Eh?
How?
No, man. The germs are Tswana.
Because it's one, very king, the gems. All right. So anyway, the gems,
Yeah.
There's a number of different types of germs.
Okay.
There is bacteria. All right. There are viruses. You've got what you call parasites. Or what other people call protozoa. So you've got basically different classes of germs. So collectively, we say those are microbes.
Okay.
They are micro, they are small. Micro, small, but they are living organisms which can cause an infection to a human being. They can cause an infection to animals, all right? So that's what microbes are. Bacteria, viruses, funguses, and also parasites, what we call protozoa. So when we say microbes, it's an all-inclusive word.
Okay.
But today we will be touching more on we'll be touching more on bacteria.
Okay.
And the treatment that is used against bacteria, which is called antibiotics.
Okay.
Yeah.
So please explain, what are antibiotics and how do they work?
Look, again, I said I didn't want to be technical because, if we are technical, we will lose people.
Absolutely.
But I think it's important for me to explain a bit that antibiotics are basically medicines that are used to treat bacterial infections. Remember I said there's like different types of germs?
Yeah.
But antibiotics are specialists in killing bacteria.
Okay.
They don't work to kill viruses.
Okay.
They don't work to kill funguses. They don't work to kill protozoa or the parasites. They just focus on killing bacteria. So those are what we call antibiotics. And how they work is that they either kill directly the bacteria or they inhibit that bacteria from growing inside a human or even an animal.
Okay.
And there are those that are specific to a particular germ, and there are those that can be used to kill a broad spectrum of germs.
Okay.
But it's not important, I think, for this talk. Safe to say, antibiotics are magical, medicines that we've had for just almost a century, and they help us to fight bacteria.
Doc, as we were preparing, you actually gave me a lot of history. You showed me when these antibiotics were founded, and you took me through a journey of at that time where the world was discovering as many antibiotics as possible.
Yeah.
And now we're actually reducing. I mean, I was enjoying the conversation.
I hope it was not too technical, though.
No, it was,
You know,
but
I
I
hope
had
it-
to grasp. But you made it simple for me to understand.
It was some form of EPET.
Yeah.
Adult basic education.
That's it.
Right. So, you know, when we talk in modern medicine, we talk about the antibiotic era.
Yeah.
Now, that era started around 1928 with the discovery of penicillin. Yeah? But I must say that historically, there is evidence that there were antibiotics that were used by the earlier, what do I call it now? The Egyptians. There's what they call Egyptian medical papyrus. That is like 1550 before Christ.
Okay.
It describes the use of moldy bread and medicinal soils to treat infections. All right? So the people from many centuries ago, they actually had wisdom in Egypt to use bread mold,
Oh, yes.
and some soils that are infected by germs to actually treat people who had certain illnesses. And this is stuff that is in the history books.
Back in those days.
1550.
Jesus.
China, Greece, Serbia, they also had these things. But I think what we are now talking about is where you've got medicines that are produced, that are produced en masse, specifically to treat illnesses. So that history, starts around 1928. I must say, though, that prior to then, a gentleman called Paul Ehrlich in 1910, he came up with what we call synthetic prodrugs, salvarsan and neosalvarsan, that were used effectively to treat syphilis.
Okay.
That is the germ called Treponema pallidum, which is a germ that causes syphilis. And also another gentleman, Gerald Domak, he came up with another prodrug called Protonsil, which is a sulfonamide, another type of drug. But really, really, the development of antibiotics, we can actually say 1928, when Sir Alexander Fleming isolated and purified, penicillin from a fungus called Penicillium notatum. Yeah? So penicillin that we use as an antibiotic was actually isolated from a fungus. All right? And this fungus had accidentally fallen into, a lab culture plate that had germs that cause pus.
Yes.
A germ called Staph aureus.
Okay.
And so this fungus accidentally
Fell.
fell into this plate.
What?
And after a few days, they noted that, this Staph aureus bacteria was dying. It was by accident that they discovered penicillin. Right? This guy, Sir Alex Fleming, I think he was an Englishman.
Yeah.
All right? But after his discovery, many other researchers from Oxford University, they then, did a much more large-scale kind of purification analysis of penicillin. And by 1945, they were able to produce in a mass production of penicillin. And these guys are Howard Florey, Ernest Chain, and Norman Hitley, the three. And so in 1945, they were all given a Nobel Prize in medicine for their discovery of penicillin.
That's incredible.
So from that time, it was a race by different researchers to find more, antibiotics, to an extent that between 1940 and 1960, we call it the golden era or the golden age of antibiotic development. There was a lot of work that was being done in the evaluation of germs and their ability to produce chemicals to fight other germs. A gentleman by the name of Selman Waxman in the 1930s, he actually described antibiotics as compounds that are made by a microbe, that is a germ, to destroy other microbes, which is other germs, So we are benefiting in modern medicine from chemicals that were found to be produced by some germs against others. And so penicillin was found from a fungus, and it then went to treat bacteria.
That's
And so that golden era, 40s to the 60s, gave us a lot of new types of antibiotics. But since the 70s, the discoveries have been far and few. So we are having less and less new antibiotics, but these microbes or these bacteria have not been taking this thing lying down, this thing of antibiotics.
They've been fighting.
They've been fighting back.
Yeah.
They've been trying to find ways and means to outsmart the antibiotics.
That's incredible.
Yeah? Because it's for survival for them.
Yeah.
Pella, if they don't do these things, they will be extinct.
They die, yeah.
They will be extinct. So, like every living organism, when it is under threat, it finds ways to survive. And so even these things, the microbes, the bacteria, they've had to find ways. So whilst we have a long history of new antibiotics being, developed, we also have got a long history of resistance, but it wasn't to the same level. It wasn't to the same level. Already by the 40s, we were aware that, the germs were producing something called beta-lactamase, an enzyme.
Okay.
To weaken penicillin. Already. But it wasn't to the extent that we are seeing today. So we've had the best of times in terms of getting new antibiotics to treat different types of germs. But we are now in lean times where there's few new antibiotics, yet the germs on the other side are working overtime to outsmart. So you're finding more antibiotics that we used to rely on as medics. They are no longer working because the germs are resistant to them. The easiest example is TB, where we normally use 4 tablets to treat TB at any one go. 4 different tablets. Nowadays, they put them in one tablet, but there are still 4 inside. Right? The reason why you are using 4 is because in that 6 months period, you don't want this germ to actually get used to all 4. Because if you used one, within a month, that one will stop working. So we use 4, so that the chances of this TB germ getting used to all 4 are minimal. Same as with HIV.
Okay.
Even with HIV, we don't use one tablet. HIV ki comrade mos ya TB.
Yeah.
They exchange notes.
Yeah.
They exchange notes. And so even with that, we use about 3 tablets to make sure that we eradicate, Nowadays, again, all those 3 chemicals are now put in one tablet.
Yeah.
So one can say, no, but I'm using one tablet. Yes, it's one tablet, but inside there's 3 tablets. So, but the aim, even with that being a virus now, because HIV is a virus.
Yeah.
HIV is as clever as TB. It knows how to survive and develop resistance, so that if you take treatment and you stop, and then you take it again, that treatment doesn't work anymore. So the problem we're talking about antimicrobial resistance or antibiotic resistance is not just limited to TB. We're seeing the same thing with one of the common germs that causes a drop. Okay. I'm not going to ask you if you've ever heard it or not.
No.
Yes.
Okay.
I'm not going to ask you that. But, gonorrhea, which is the commonest STD or STI.
Yeah.
Nowadays, when I was still a student, when somebody comes with that, you jova them with benzyl penicillin.
Yeah.
And then it's gone.
Doc.
Okay. And then the guy goes out with a leg numb, and you hope that next time utoba more careful, So nowadays, these germs that cause gonorrhea, they no longer respond to benzyl penicillin. You now have to give other types of antibiotics to be able to eradicate it. We are also seeing it, in other infections as well. So other pneumonias. A lot of people who have pneumonia, we would give them again penicillin, some type of penicillin, maybe with a drip or with tablets if it is mild. And then within 3 to 5 days, they are sorted. Nowadays, we have to find other newer antibiotics. So that is the problem we're dealing with. The resistance from the frontline drugs that we used to use is now forcing us to use more expensive drugs, which means the cost of healthcare is becoming more hectic. And some of these we can't treat at all, even with alternatives. And so people are dying. Nowadays, they are talking about 1 million to 2 million people who are dying from infections that used to be treatable, but that can no longer be treated because of the resistance.
Doc, you were saying the era of the golden era of the development, and then now we are in the lean years. Now,
we're in the lean years because now the discoveries, the number of new antibiotics coming up is very few, very far and few.
Yeah.
If I look, for example, in the 1980s, we came up with a group of drugs called carbapenems and monobactams. That's just about 3 in the 1980s. And then in the 2000s, we got antibiotics called lipopeptides and pluromutylins and oxazolidinones. But if I compare it with that golden era, 1, 2, 3, 4, 5, 6, 7, 8, 9, there was almost 12 in the 60s. Now, since 1980 to date, maybe we've got just about 8 in almost 50 years.
What?
You see?
So
clearly, so the outputs in terms of new antibiotics is definitely much, much, much lower. So we are producing less new antibiotics, but we are getting more and more resistance.
Okay.
So our potent ammunition against germs is no longer potent for most of the germs. And so we are facing a situation where in the next 20 to 30 years, we might have what people are talking about as post-antibiotic era. An era where there are not many antibiotics that we can use to treat infections. So we will face a situation like during the World War One, where a lot of people did, who died, did not die from the gunshots and stuff. They died from the infections relating to the injuries they sustained, and so, I mean, modern medicine, which is something that I qualified in, is gonna be made very important, once many of these germs have outsmarted the antibiotics, because these are the things that we know. Even if you're gonna go and do an operation on you, we make sure that we put you on antibiotics so that there's no infection and all of that. But now, if these things are gone because there's resistance, then it spells trouble in terms of the treatment of patients.
Absolutely, Doc. I think earlier on in our preparation, you spoke about how we as Africans, before modern medicine, had some form of solutions, and you shared some of them with me.
Yeah, I mentioned that, before the antibiotic era, in the early 1900s, yes, people were dying in numbers, but, various communities had, their own treatment regimens. That's when people who had deep knowledge of herbs and their healing properties were actually very important people in society. I mentioned that during the, when Jan van Riebeeck came to the Cape of Good Hope, and some of the people were dying from things like malaria. So somebody said they don't know what a parasite is. Actually, malaria is a parasite. It survives by eating your blood. So people who had malaria, they were given umhlonyane. Umhlonyane to try and deal with the effects of malaria. And so there were many other medicinal plants that our forefathers used to use. Yes, they may not have been taken through research labs and whatever, but they did work to treat different things. Now, I mentioned to you that the early Egyptians, the Greek people, the Serbian people, the Chinese people, they had great knowledge about some of these agents, herbal medicines that could be used to treat various things. So, but those things were not as potent as the antibiotics. So, as we are now facing a future where the antibiotics that made modern medicine as good as it has been, we're facing a future where there may not be enough of antibiotics. And so there is a need globally to actually try and get as many new drugs developed as possible to fight germs.
So, Doc, we're hearing that we are now hearing about antibiotics resistance or antimicrobial resistance. So, what exactly is that?
So, I think I've been explaining that.
For sure.
It's basically, so if we are talking the group of germs, which I called microbes. So when we are saying antimicrobial resistance, we are saying resistance by different germs to what used to be able to eradicate them. Right? It's broad umbrella microbes. But there we're talking antibiotics against bacteria. We're talking antivirals against viruses. We're talking antifungals against funguses. Fungus like athlete's foot. You know athlete's foot when you sweat a lot between your fingers, and sometimes you don't wipe properly there by the balls. In that area, you wash, and before you've dried up, and then you've already wearing your boxer shorts and stuff, and the area is wet, and then you find that,
Wababa.
Wababa, there's some redness there in that area, you know.
Yeah.
That's why after washing,
Yeah.
you must just you
Eh.
know, open up. Ushabweke moya. So, but anyway, that germ that causes that,
Yeah.
you know, because it's always wet in the area there,
Yeah.
you know, or, you know, between
Your toes.
the toes,
Yeah.
for women with big breasts,
Underneath.
under the breasts, you know, other people, you know,
Yes.
so funguses, they like warm and wet areas like that. So you're now finding antifungal agents that are no longer working
Okay.
because those funguses, you know, or fungi, you know, proper terms to say fungi.
Okay.
Those fungi, zijwayele manje this cream, yabo.
Oh.
Yabona mo uthi hayi ngifuna athlete's powder doc.
Yeah.
Hey, kwababa man.
Yeah.
Yabo.
It gets used to it.
It gets used to it, you see.
Yeah.
So that's resistance.
Oh, okay.
You know,
Yeah.
malaria, we used to use what we call, you know, quinolones and other drugs to treat malaria.
Yeah.
Nowadays, most of the malaria germs no longer respond to those drugs. By the way, the very drugs that some people, you know, were trying to use them got COVID.
Yeah.
You know.
Oh, yes, I remember those ones.
Exactly.
Yeah.
Yes. You know, we no longer use them for malaria. We use something different. But the point is, for each of these different types of germs, the stuff that used to be used and that would kill them, there's no longer a guarantee that when you use those things, they'll work. Because if it is one of those germs that are now resistant, we may not be able to treat that. And that becomes a problem.
Yeah. Doc, you mentioned earlier on that we have a pandemic, a new pandemic, but this time it's by experts who really say this, and also WHO lists it as a number one.
It's one of the top 10.
Yeah.
It's one of the top 10.
One of the top 10 health concerns in the world.
Yes, exactly.
Please explain that, Doc.
So, you know, like I mentioned earlier, so we have a situation, all right? We have a situation globally. That is, when I say globally, in all 7 continents, there is a problem of germs that are now buddy with antibiotics.
Yes.
And that is creating a problem.
Yeah.
Because now when we send these antibiotics to go and fight with these guys, instead of fighting,
they become friends.
They become friends. And, but then, whilst it's doing the friendship thing, the bacteria is busy causing harm. So we're losing people. People are dying.
Yeah.
You know, so basically that is the challenge. And so in May 2015, there was what we call a world, what is this thing now? Where different member countries of the WHO, they sit, they call it a World Health Assembly, once a year. You know, they sat and they were considering this thing, you know, and so they said, we must all have a global program of action. You know, the World Health Assembly, which took place in May 2015, they said we need to have a global action plan to ensure prevention and treatment of diseases with safe and effective medicine. But they also said there must be a global action plan on antimicrobial, resistance. And they focused on 5 things: improving awareness and understanding of the antimicrobial resistance, strengthening the surveillance and research of new resistance to different treating agents, reducing chances of infection by going back to the basics like washing their hands, you know, and all of that. That is basic hygiene, and using antimicrobial medicines only when it's necessary and use it optimally. and also ensuring that there is sustainable investment in getting new antimicrobial agents. So the slogan that has been used since 2015 was antibiotics handled with care. But now that we are looking beyond bacteria, they are now talking about antimicrobials. That is, we must handle them with care. That is from 2020 to now. So the key issue is, let's not create problems for ourselves. Let's use these things when they are absolutely necessary. Yeah.
Absolutely. Doc, I mean, that's the guidance from the WHO. So
These are the custodians of health, yes.
Yeah. So what is the responsibility then of ordinary people against, what role can we play against AMR?
You see, ordinary people, I'm saying ordinary as in non-healthcare workers,
You started ka Aishka, right? Here comes the problem.
Because when I used to be in my practice, muthu tlo fitla a tshwere ke common cold or o tshwere ke flu. Doc, please man, kenya antibiotic there. Kenya antibiotic. He's telling me that I must put antibiotic in the prescription. But utlile ka an infection ya virus, common cold, or flu, which is a virus. And antibiotics are not effective. During COVID was caused by SARS-CoV-2, which is a virus. But people were insisting on being put on antibiotics, So basically, there are things that we need to do as individuals. One, we must use antibiotics that are prescribed by certified health professionals. Two, we must never demand antibiotics if your health worker says you don't need them. Three, we must follow your doctor or nurse's advice. If they say use these for 5 days, don't use them for 2 days. When you feel better, then what it look like. Finish the course of antibiotics. Because if you use them for 2 days, what it look like, next time when you complicate, you want to use the same things. By that time, the germ will have found a way against those. But also, we need to go back to the basics of washing our hands, prepare food hygienically, avoid close contact with sick people, practice safe sex, and keeping vaccinations up to date. But sometimes when the blood rushes to certain organs, people don't think
that organ takes over.
That organ takes over, and they do things. But anyway, so that is, as individuals, those are the things we need to do. We need to take responsibility, and not use these things unless they're absolutely, necessary. And I think for the policymakers, for the government, they have a duty to prevent and control spread of this resistance to antibiotics or antimicrobials. One, there needs to be a national action plan. I have not heard of a national action plan in South Africa. The first time I knew they are taking this thing seriously was during the week when Gauteng Department of Health issued a warning to South Africans or Gautengers, to play a positive role in reducing this resistance. So at least they are doing something on the awareness side. But in terms of a national plan, a comprehensive plan, I've not heard about it. Maybe I'm ignorant. Government must improve their surveillance of these resistant infections. They must come up with policies, programs, and implementation of infection prevention and control measures. And they also need to regulate and promote appropriate use and the disposal of quality medicines. And they must disseminate information to every South African about this, because this is the biggest risk that is facing humanity as far as infections are concerned.
Doc, I just want to take you one step back. In our preparation, you actually explained one thing that a lot of us get wrong. You were talking about how we make use of the word called pandemic, and you were explaining the difference between pandemic and endemic. There's another word you used. Kunje, what's the other one, Doc? You said
pandemic, epidemic, and endemic.
Yes, please, if you can explain that.
Yeah.
Where
I think Kitlotomaga pandemic.
Okay.
Yeah. You know your comrades. Your comrades,
Yeah.
You know, I think many of them heard the word pandemic for the first time during COVID.
Yeah.
Now they are using it even in inappropriate circumstances.
Yes.
When you talk of a pandemic, we're talking of illness or a disease that is causing havoc in all 7 continents. Yeah? Then we say it's a pandemic. Now, COVID-19 was causing trouble across all the continents.
Yeah.
So, WHO, around March, I think 3rd of March 2020, they declared it as a pandemic rather than a disease of international concern. Before then, they said it's a disease of international concern. Okay. Then they said it's a pandemic, around the 3 of March. So all 7 continents are challenged by the same thing. Now, so what we're talking about today, antibiotic resistance, is actually a pandemic, but it's a much more silent pandemic. We're not hearing a lot of the numbers. You remember we used to get daily numbers of how many people are dying.
True.
You see?
Of course.
But we are not at a point where we are actually sharing information like that, because then you make it real. You know? We're not doing that. So that's a pandemic. An epidemic, you've got a problem of a disease or an infection that is spreading in a country or a number of countries, let's say within a continent.
Yeah.
Let's say SADC, or South Africa, We can't call it a pandemic when it's happening in one continent, a region of a continent like SADC.
Like GBV is not a pandemic.
Yeah, my comrades. Well, now, right now, we are at that thing of no violence against women and children and people with disabilities.
Yeah.
Ne?
Yeah.
16 days of activism.
Yes.
They're going to stand there in the podiums, and talk, in South Africa, we've got a pandemic of GPV.
Yeah.
How can it be a pandemic, a problem that is in a country? I'm not saying other countries don't have the problem of women abuse, but you can't be describing a national problem and already be saying a pandemic.
Yeah.
Yeah, but is this thing, little knowledge sometimes can be, because they want to emphasize
it's a problem.
It's a problem. And the only way to emphasize is to actually say a pandemic.
Yeah.
Yeah. Yeah. But it's a pandemic.
Yeah.
Exactly. And endemic, when it is within a country, but a region of a country. Let's say Mokitwango, Eastern Cape.
Yeah.
Kunali epidemic, whatever, the worm that causes epilepsy, from pigs that are not properly cooked. It's endemic in that area that people eat pigs whose meat is not properly cooked, that has got the larvae of a particular worm. We call it a cysticercosis. And the infection is cysticercosis. And then somebody has got epilepsy later because the larvae got to the brain and then it made a cyst there and you start having epilepsy. That thing is is endemic in the Eastern Cape.
Okay.
Wabon?
Yeah.
But you can't say that thing keep pandemic. Wabon?
Yeah.
So Kikupa man, when you have your interviews, Lima comrade,
Yeah.
uba correct.
Okay, no,
Please.
man. It's not the right usage of the word.
Please, comrade,
Yeah.
with due respect, honorable comrade,
Yeah.
let's not use the word pandemic on this matter.
Please retract it.
Please retract it, honorable MMC.
Yeah, just like that.
Yeah.
So, Doc, you spoke about the WHO guidance. You spoke about the role of the policymakers,
Yes.
the role of the individuals.
Yes.
So now, what is the role of the healthcare workers in this turn? The doctors who actually prescribe these antibiotics. Sometimes you give in to the patient.
The pressure.
Yeah.
Yes. It's very difficult. I mean, if you've formed a relationship with a patient, sometimes you give in and do stuff. It's like mutulovile komsebenzini.
Yeah.
On Monday, watla, doctor man, next week papalaza man. Kikupa ungaye sick note nyana. Some guys, because they are so used to their patients, they feel for them and end up signing a sick note marumutu akuli.
Yeah.
Unatswereki papi fela.
Yeah.
And usually utlotla kala bunne.
Yeah.
Ne?
Abatla Friday off.
Oh. Ari doc. Akaya msebenzini hutluga mantaga. It's Wednesday. And uri ke batlo ya msebenzini kausana.
Yeah.
Thursday.
Yeah.
Because especially those who earn weekly wages.
Oh. Yeah.
Yeah, so utlokena ko msebenzini kala bune labotlhano. Mara uri no negnali thogo.
Yeah.
As a doctor, you're not supposed to issue that sick note. Because you were not there.
Yeah.
You don't know if this person was really sick with this thing.
Yeah.
The least you can do is to write on the sick note and say, as I am informed, B says he had a headache.
Okay.
Wabon?
Yeah.
Then the employer will then know that you said, as I'm informed, you didn't say according to my knowledge.
Oh.
So our guys will say according to my knowledge. Some of our guys, some, the unscrupulous ones.
Yeah.
As if umuboni mandah.
Oh.
And we backdata the sick note. It's not supposed to. So the point I'm trying to say, with a bit of pressure from our patients, sometimes we end up doing the wrong things. So to answer your question nicely, in terms of what should the health workers do? One, obviously they need to prevent and control the spread of this antibiotic resistance by ensuring that their hands, instruments, and environment are always clean.
Yeah.
They only prescribe and dispense antibiotics when they are absolutely needed, according to current guidelines, right? They report resistant infections to the surveillance teams. They talk to their patients about how to take antibiotics correctly for the full period and the dangers relating to misuse. Sometimes Sipo takes the treatment for 2 days and then he feels better, and then Figo is coughing, unali sihuba, and then he gives him ugaya Figo, the pills it's how.
Yeah.
That is not how things are supposed to happen. So that is misuse of these antibiotics. So that's what we're talking about. So we have a duty to educate our patients on how to use these things properly, but also to encourage them to vaccinate for those diseases that you can be vaccinated for. Kemubona Figo mo he's taking a video because ubatlo bonisa batho gore ya nekulela ka yena. But anyway, so that is really we need to be responsible as doctors. Whilst we love our patients, but we need to see the bigger problem, for society when we do these things.
Absolutely. Doc, there's one last video that you wanted us to look at, and then maybe after that we can then close it off with the role of pharmaceutical companies and what role should they be playing Can I play that video?
Please go ahead.
Okay.
You can play the video.
Let's go.
By 2050, it is estimated that millions of people could die every year due to antimicrobial resistance. By 2030, it could cause global GDP to drop by $3.4 trillion and push 24 million people into extreme poverty. But what is antimicrobial resistance, or AMR, and why should we be concerned? Antimicrobials help treat infections and diseases in humans, animals, and plants, and allow us to perform complex surgeries with greater success. You may know them as antibiotics, antifungals, antiparasitic, or even as disinfectants. As more antimicrobials are used and released into our environment, microbes are adapting into superbugs and are one of the biggest threats to global health. With growing resistance, many antimicrobials that are used to prevent and treat infections are becoming ineffective. But this is not just a human health issue, it's also an environmental issue. AMR is linked to the triple planetary crisis of climate change, biodiversity loss, pollution, and waste. Our changing climate affects AMR. Higher temperatures can be associated with increases in AMR infections. Extreme weather patterns can also contribute to antimicrobial resistance. As flooding increases, wastewater spreads faster, accelerating the spread of resistant microbes. Impacts on microbial biodiversity may affect carbon and methane cycles, which are directly involved in regulating Earth's climate. Microbes inhabiting natural environments are sources of pharmaceutical discovery. However, in recent decades, land use changes and climate change have altered soil's microbial diversity, which may affect our ability to make medical breakthroughs. Pollution in key sectors of the economy contributes to the development, transmission, and spread of AMR. Reducing pollution created by the pharmaceuticals, agricultural, and healthcare sectors and municipal waste and wastewater is essential to reduce the emergence, transmission, and spread of superbugs. We need to tackle antimicrobial resistance through a One Health response, which refers to the interconnectedness of human, animal, plant, and environmental health. By working together to establish strong policies and regulation and prevent and manage chemical and biological pollutants, we can limit the development and spread of superbugs. To reduce the spread of superbugs, the world must cut down pollution today.
There you have it, Doc. Sure, very scary.
Yeah, scary stuff. This is the reality, guys. And whilst we may not be able to stop it, that is the emergence of these resistant germs, but we can slow it down by just being responsible in terms of how we do things. So, and each one of us has a role to play, whether we're patients or relatives of patients or friends. We're running pharmacies or we're medical doctors. We have a duty. I mean, you asked me a question here about what is the responsibility of the healthcare industry to prevent and control the spread of antibiotic resistance. Well, most important thing, I mentioned that we are in a lean period in terms of discovery of new antibiotics or new antimicrobials. So we need more investment in research. We need a development of new antibiotics, vaccines, diagnostics, and other tools. So that's what the industry must do. And remember, we've been talking more about human beings, but we must not forget that everything we've said applies equally even to animals, so the agricultural sector.
And plants.
Yes. So we must only give, that is the vets, must only give antibiotics to animals that are under vet supervision. they must not use antibiotics for growth promotion or prevent diseases in healthy animals, because there is this thing now, to try and get animals to grow quickly. They hoy antibiotics and other things,
Like
in
our
there.
chicken, yeah.
Yes, our chicken. We must vaccinate animals rather than wait for them to be sick and then hoy antibiotics. And generally, we must promote and apply good practices at all steps of production and processing of foods from animals and plant sources, and improve biodiversity of farms and prevent infections through improved hygiene and animal welfare. So that is from an animal point of view.
Yeah.
But obviously, we're more worried about human beings. So that's why most of what we've been saying is around what happens to human beings. If we don't make the right decisions and do the right thing, in 27 years' time, which is 2050, we may be in serious trouble. We may be turning the clock back to the period before there were antibiotics. And that will be a sad day for modern medicine, and it will be a sad day for humanity.
Doc, that is powerful. We've come to the end of the show. I've learned a lot. Thank you so much for raising the flag, Doc. It's a red flag.
Yeah, no, man. We must avoid infections.
Where possible.
In every way. Re tlhapa matsogo, re kenya di kondomu, kaofela nje, we avoid infections. If we are the cough etiquette, so that we don't spread the germs. All the things we're being taught kanakoya COVID, we must apply them now, not because renahana or COVID itlo, but it's just a right thing to do.
Absolutely.
Yeah.
Doc, this has been so informative. Thank you very much. I've certainly enjoyed listening and learning new words.
Yeah.
Doc.
Anti-Microbial.
Doc, how do I even pronounce some of these words?
There must be a reason for Muto.
Yeah.
Uspendile 6 years go medical school.
Yeah.
So there's a difference.
Something, yeah. It's been
but,
amazing, Doc.
It was nice, trying to unpack something that sounds technical, but actually unpacking it, making it accessible, that's what we should be doing. This is where I think our government needs to focus, simplifying matters of health to make people to understand why they need to do certain things, rather than just being told, don't do this, and you don't know why.
Absolutely. Doc, I think before you close, there's one thing that just popped in my mind, is that you spoke about the guidelines from WHO. One of them, you said, they actually, in our preparation, you said, actually they said countries must look at their own ways of using traditional medicine, or I don't know, I can't remember how you put it, but
yes.
What is the role of traditional?
So, I think there was a World Congress on traditional, medicine, and the DG of WHO at the time, Margaret Chan, did encourage countries to actually regulate, that is, recognize traditional healing space and regulate it, rather than pretend that it does not exist.
Absolutely.
But the upside of doing that, of getting them closer, is that because the herbalists within the traditional healer space actually have got intense understanding of some of their medicinal plants, it could well be that some of our new antibiotics can come from some of that, and not only antibiotics, but I mean other medicines that are actually useful, because there's always been this thing that we pretend they don't exist. All we see is when patient comes has got a kidney problem or a liver problem, and we say, yeah, look, they are enemas, look, they are herbal mixtures. But the majority of people who make use of these actually don't end up in hospital. So I think the arrogance from modern medicine has to go down. We must understand that we're running out of options to treat a number of diseases. And it may not have to have collaborations with traditional healers, and bring in science by researching some of the herbs that have been used for thousands of years. That way, I think, because nature always provides. But, like I said, penicillin came from a fungus.
Yeah.
You see? So that's nature.
True.
Yeah? From bread mold, fungus. So how many other things are out there in nature that could be of help to us? Yeah.
Absolutely. Doc, this is how we come to the end of the show. I've enjoyed it very much. Like I said earlier on, I've learned a lot, and thank you for empowering us and educating us.
Please tell your comrades about the pandemic.
They must stop using that word
Yeah.
inappropriately.
Yeah, no, we've got a pandemic of GBV here in South Africa.
Doesn't work like that.
No.
Thank you very much, Doc.
Okay, lovely. And thank you to everybody who has watched this podcast. We aim to inform and do so in a way that is enjoyable. Yeah.
Absolutely. All right, we're signing out.